right, I'm going to take this off here. I was really excited, you guys, that I'm tall enough to see over the podium. That normally does not happen. So I'm so excited. I need to get a picture before I leave so I can tell everybody I can see over the podium. Thank you. So my name is Letizia Smith, and I'm a psychiatric mental health nurse practitioner. I've been in practice for about 15 years, and I'm also an assistant professor at Vanderbilt School of Nursing in Nashville, Tennessee.
Good morning, everybody. I am Brandee Madden, and I am also a psychiatric nurse practitioner. I work with adults and primarily in addictions. And I have also been in practice for about 15 years, and I am also an assistant professor of nursing at Vanderbilt University School of Nursing. So thank you for joining us today.
All right, so we want to start off by just letting you know that we do not have any conflicts of interest before we move forward with this presentation. So at Vanderbilt, we've been really working hard at trying to incorporate diversity, equity, and inclusion efforts into our coursework, into our clinicals with our students, and just making it part of the environment all the way around. So because of that, Dr. Madden and I started talking about what could we do to make sure that that message was really being delivered to our psychiatric students, and we stumbled upon or thought about the cultural formation interview. So we'll definitely talk to you guys about that today. We also want to discuss disparities in mental health and how that impacts the health care that people receive. We'll talk about DEI efforts that are important in mental health, and then finally we'll consider DEI efforts in psychiatry. All right, so first I want to open us up by talking about disparities in mental health. And I really feel like this alone we could spend the 20 minutes easily, but I'm just going to try to hit some highlighted points. So certainly when I was looking in the literature, it was interesting to find that on average, 11% of America, or most of Americans spend about 11% of their income on healthcare expenditures. But African Americans spend on average about 20%. So already you have a group of people who historically are not making the highest in comparison to other groups, but they are spending more on their healthcare insurance or healthcare expenditures. And I can tell you now that when people have to choose, psychiatry is low on the totem pole. They're going to get their blood pressure medicine, and rightfully so. They're going to get all the other things, but we're not going to spend any more because we don't have it to spend on psych illnesses and things of that nature. Then we also have to consider stigma, and stigma really can go across a lot of domains. One, we have individual stigma. So some cultures and groups, psychiatric mental illnesses may be seen as a sign of weakness. You may be afraid that people are going to think that you're crazy, or that it's going to impact how you can move and advance in a society. And then you also have to consider some of the organizational factors that contribute to stigma. So for instance, in psychiatric care, at least in the state of Tennessee, most insurances don't really cover therapy, and they don't really cover you going to see a psychiatric provider. So that creates an issue or a barrier for people, and again, makes it harder to seek that help. Another big thing that we talk a lot about is the lack of diversity among providers. And so I feel like this problem is multifaceted. We know that we really don't have a lot of faculty of color in schools of nursing. And then because of that, a lot of times we're not graduating as many students of color. And then therefore, when we're in our communities, our providers are not very reflective of what the community looks like. And I don't know about you, but when I'm talking about my deepest and darkest secrets, I want to be able to talk to somebody that I feel like I can relate to, that really understand what's going on. And so I think that can also make it difficult when you're going in and you're seeing somebody who looks different from you, who may not understand exactly where you're coming from culturally, and you're having to share things with them. And then finally, access to care. This is just huge in psychiatry alone. Someone was just saying, I cannot find a psych NP that sees children. There are so many communities. I'll go back to say one of my big things that I do at Vanderbilt is I help with clinical placement. And there are so many communities across the United States that they just don't have psych providers. People are seeing primary care physicians, everybody except for a psych provider. And so definitely that is a barrier to care. So then, that brings us to the question, what is DEI in psychiatry? Well, first I wanted to talk about APNA. That's our Psychiatric Nurses Association. And so recently they've definitely identified the fact that in order to improve mental health outcomes, we really have to think about culture and how it impacts individuals and treatment. And they certainly believe that psych NPs should play a central role in advocating for DEI treatment with their patients.
Again, what is DEI in psychiatry? So we have to think about culture when we're talking about DEI. So every culture has a different way of looking at mental health. And culture impacts the language people use to explain their symptoms. They explain how they feel about these symptoms. So when you're speaking to people, you have to understand where they're coming from, their language, the symptoms that they're bringing forward, because, and I know in nursing we always talk about the common example that people come across is high blood or the sugar. So the sugar. So people talk about the sugars all the time. And so you have to know about people's culture and their language. And that's the same thing in psychiatry, is understanding language that comes across. And then culture can also affect how much support you may or may not receive within your community. Because there's, in some cultures, mental health care is very ostracized. And you are stigmatized within your own culture just for having a mental health concern. So think about this. In the United States, that the 26% of the population are members of an underrepresented group, but only about 6% of practicing physicians come from these groups. And nursing is no better than that. So 6% to take care of 26%. And that's not a great statistics. Like we need to have more of us out there helping the rest of us. And so clinicians, we have to be mindful of the multiple challenges that are presented based on social determinants of health. And so that's my next slide, is the social determinants of mental health. And I know everybody knows about social determinants of health in general, but this is specific to mental health. And this reflects how trauma, poverty, discrimination, education, and other aspects can affect mental health care. And so I'd like for us to think about social determinants of health in these few examples. So think about having a child who is hyperactive, disruptive. Think that they could maybe just be hungry or don't have sufficient housing or a place where they can play or go outside. Those are all social determinants of health. Then also think about ADHD and school performance. So you have a child that, when we think about that, sometimes they go untreated. And if they go untreated, they can be labeled as, quote, disruptive. And when they're labeled as disruptive, that means they're suspended. And then suspension then leads on to juvenile justice. And you can see how these things perpetuate themselves. And these are all social determinants, like things perpetuating themselves to adverse health outcomes. And then also thinking about trauma. I'm sure we've all heard of ACEs, adverse childhood experiences. So think about that. We all know about we have police brutality, systemic racism. These are all things that we have experienced as people of color, and we understand it. But we're always in survival mode, and these experiences that we have increase our physiological stress, and that also leads to adverse outcomes, and not only in our physical health, but in our mental health as well. So as I mentioned, we did this presentation for our students at Vanderbilt, and so So with this is the cultural formulation interview. So this is something as part of the DSM, which is what we use in mental health as part of our diagnostic tools. And so the cultural formulation interview is just a questionnaire. And it's, as I said, it's in the back of the DSM. Like, you don't notice it if you don't look for it. And it is really essential in defining culture within psychiatry. And so it's divided into 4 domains. You look for the cultural definition of the problem, the cultural perceptions of what's going on, cultural factors that affect coping, and cultural factors that affect help seeking. So again, here's domain 1. You look to find people's own experiences and try to find their own view, because people will come in with their own view of what is going on. And you as a provider, you have your own view of what's going on. So again, culturally, we need to know what they think about what's going on. And domain 2 is to clarify what that person's social network thinks of that, of the problem. Because again, people have different ideas of what's going on and what is a problem. Domain 3 is factors that affect coping and past help seeking. Explore what the person has done in the past to cope. So for this one, I have the example of a man who identifies as a gay man, and he also uses substances. And so he wants to get help for his substances, but his family wants him to get help, but his family doesn't agree with his lifestyle and his sexual orientation. So he's got 2 things that are going on, well, several things that are going on. He's got his conflict with his family because of his sexual orientation. He wants to get out of drugs, but his friends and his social group, they are constantly using drugs. And so in order to get self-acceptance and to get that social interaction, he continues to use drugs with his social peer group instead of getting support from his family, who does not agree with his lifestyle. And so again, knowing what helps with coping and past help seeking, and knowing what affects the current help seeking as well. Next.
All right. So again, like we mentioned, we had our students pull out the CFI in class, and we had them practice on one another and think about how they would incorporate this into their own practices, and really just having the discussion, putting it on their radar, making it something that they really have to consider. So that's one of the opportunities that we can use to definitely help those who are disenfranchised. But I want to talk about a few more. And let me tell you, I must have been tired on this last slide, because you guys will see that some of these are listed like 3 times. I apologize. But one of the things is collaborative care. We talked about how access to care is a big issue. And so if we have primary care providers or FNPs working together with social workers and kind of screening, and then getting the people who really need to be seen to the psych NP, that kind of clears up some of the time that may be wasted of getting people in front of them that may not really need to see them. They might need other resources. So collaborative care certainly is one of the big things. Another thing that COVID taught us is that telepsychiatry is important. We were able to reach people that we hadn't previously been able to reach, and so them getting to the appointment was not an issue. I know in the clinic that I worked in, our no-show rate went way down when we started using telepsych, and we really started to see people. Now that, of course, comes with its own issues, because you've got to learn how to connect with people over Zoom or whatever it is that you're using. But certainly I think this can be a tool to help with access to care. And then finally, education and mental health care. Again, I talked about this being a multifaceted issue. We need to make sure that the research reflects Black and brown bodies and not something different. This is the research that we're using. And so when we use it, we want to make sure that our voices are being heard. And I'm excited to announce that on Friday, I found out that a colleague and we got a small grant, and we'll be working together to help improve the number of faculty of color in the SNRS region. So we're going to hit the ground running on that next month. Certainly something that I think we'll be doing to kind of help out with that. So again, we just need to be doing the work so that people hear from us, and that reflects in the education and literature that's out there. And that, we're almost out of time. That's everything that we have. Here are references. Does anybody have any questions for us?
Sharing with information as others. So what resources would you suggest that I use while I'm waiting to get patients into with the psych NP, because the wait may be up to 3 to 6 months.
Wow.
Yes. That is a good question. So I know in our communities, some of the things that I go to would be a federally qualified. Yes. So community mental health, but they're often overwhelmed as well. Now, I don't know if Psychology Today is a resource that you have in your area, but you typically can get on there and reach out. The problem with that is that a lot of private practices, like I mentioned earlier, they're not accepting insurance, so people are going to have to pay out of pocket. Now, you might find some organizations or private practices that are willing to do super bills, but that requires a level of confidence on the individual reaching out for the help, because they've got to be able to reach out to their insurance company and then communicate what they need and get that super bill turned in so that they can be reimbursed. I don't know.
Can I clarify my question? My question is more so resources for me to treat them while I'm trying to get them into.
Okay, gotcha. Good question. Do you have?
Let's wait for 6 months.
Yeah.
Yes.
So are you an FMP? Okay.
Yeah. So as an FMP, you do have qualifications to treat, basic mental health. But what I would say is just collaborate, knowing a psych NP. So you have connections with the psych NP already in your practice, but make sure that you can be able to talk to that person about any cases that come up, because in your new practice, you're going to have some cases that come up that are going to maybe challenge you a little bit. And so make sure that you have someone that you can reach out to and maybe can mentor you a little bit until you can find someone that can really take over that mental health care. Because it is within primary care, being an FMP, you're gonna have a lot more of those mental health care cases. So knowing a psych NP that can really collaborate with you and just give you some guidance is going to be beneficial, because otherwise you really just need to just get in and go in and get some more education on the matter. But yeah, mentoring, having a collaboration with the psych NP, someone that you know and trust that's going to give you good advice on how to treat your patients.
The only other thing I'll add to that, APNA has a really good suicide training. I would suggest taking something like that, because you also want to be prepared for the worst case scenario. What do you need to do? What do you need to look for? So I would look into that too. APNA, it's the American Psychiatric Nurses Association. Mm-hmm. Yeah. So I actually work in a facility where we see the sickest of the sick, the poorest of the poor. So our people did not have that, and we got on the telephone. And we called them and we talked to them on the telephone. Now, that does create some other issues. I learned pretty quickly I needed to know where they were exactly, because I definitely had someone tell me they were suicidal and then they wouldn't tell me where they were. And now I know they're suicidal and I need to do something, but I have no idea where they are. So, you learn some of the things that you need to do that safely. But certainly the telephone has been something that I've used in the clinic that I'm in as well.
Please, let's thank Dr. Madden and Dr. Smith.